of International Dairy Federation, Food Safety and Standard Authority of India, and the BIS. Over to you, sir.
Thank you. I'll share the screen.
Yeah, sir.
Is it visible now?
Yes, sir. It is.
Yeah, it is perfect.
Full screen, yeah.
Yes,
okay.
Sir.
Yeah, good afternoon to everybody. And the outset, I would like to thank the organizers, F&I, and also Amway for giving me this opportunity to talk to you on safety and efficacy of nutraceuticals. So the basic requirements, you just now you had a very very good talk on the various aspects of this, nutraceuticals. The point that comes to us is that in one of the questions I saw that how much they should take and what concentration it should be, that pomegranate they were talking about. So the point that comes to us is that it should be safe. That is the first requirement. So this thing is audible clearly? Hello?
Yes, sir, you are audible, sir.
Yeah, absolutely.
Yeah. So, and second thing is, see, when we say nutraceuticals, it is for some physiological benefit that we are expecting from that nutraceutical. So, it should serve the purpose. These are the basic requirements. So, the most important thing first will be to talk about safety. So, this, of course, definition is essentially for food safety. But we can actually apply, because now, all these nutraceuticals, dietary supplements have come under FSSAI. So we will be looking, this can be applied to nutraceuticals also, maybe with slight the deviation from this thing. It is a degree of confidence that food will not cause sickness, harm to the consumer, either in long or acute or chronic. And consumer, when it is prepared, this prepared served also can be actually, maybe Dr. Rama Vaidya can actually watch for it, is that the way you prepare some of the botanicals, nutraceuticals. So there is a way to do it, and it should be water extract or alcoholic extract. So nothing else is permitted. So if you do that everything, and finally, according to intended use, what is the intended use? Again, is the efficacy or the effect that we are expecting from it. So the basic concept of safety is that the dose. So dose decides the toxicity of any product. So dose alone will tell you whether it is used is a beneficial or toxic. So by this definition, we have to look everything from that point of view, so that we understand. So what is the food safety, safety of nutraceuticals? So but the one important thing that I would like to make here is that your food nutraceutical or food supplements or functional foods, they are actually the country specific, because it all depends upon our dietary habits, food consumption patterns, and the type of foods to eat, the type of foods that we get in our place. So it has to integrate with the regulation. There will be interlinked with this regulation. So maybe we'll be using the international concept of safety, but we have to actually also see what is the regulations, because these regulations are made for country specific requirements. So if you see that this regulation, it came in 2016, of course, Dr. Vaidya probably was the major contributor for this, is that when they wanted to make these regulations, there was a lot of discussion on which are the things which have to be put in this. So they have actually the Unani, Siddha, because these are our traditional systems based on our foods that are available and the type of diseases that we get. So Siddha, Unani, and also the Ayurveda, and also of course modern medicine also has contributed some of the nutraceuticals. So all those things have to be put into this. So they have actually prepared a list of nutraceuticals and ingredients, they call it. Sometimes it may not be one single component, it may be a combination of 2-3 things. So there are 1 to 6 schedules provide a list of nutraceutical indicators whose safety has been established. So now if you see this list, you don't need to, because FSSA already has actually listed the nutraceuticals or ingredients which can go as a part of nutraceuticals, where safety has been established. There is no further research is required on that, especially on this thing, unless if there is one more issue is for some of those nutraceuticals or even botanicals, they actually also have given the minimum and maximum dose that can be given. Okay, for some of them there are no safe limits because at the time of this one there was no available information on those things. And of course, when a person is trying to make a product out of these nutraceutical where safe limit has not been given, then they can use the international reference material to actually, this thing, address the issue. So any nutraceutical other than those listed in regulations needs prior approval. So from 2016, of course, this has been amended recently to 21. So anything other than this requires a prior approval. That means that you have to have a lot of information on the toxicity and safety and also the efficacy of those things. So what I am trying to make here point is that your research, everything is interrelated with the regulations that we are in this, because there could be some differences between the type of foods that we eat and type of problems that we have. So the regular toxicological requirements for any new compound, like what we do in additives also, is acute toxicity, short-term toxicity, long-term toxicity, mutagenicity, carcinogenicity, teratogenicity, multi-generation studies. And so these are the classical toxicity studies that are required if it is something new is coming. And then finally, you add up having that low observed adverse effect level. Once you have all this data, so you have to find out from the research studies, because one person cannot and one organization cannot generate all this data. It will be actually collated from all the information all over the world and try to identify what is the low observed adverse effect level for this nutraceutical. And then from there, we actually derive no observed adverse effect level. Okay, so then we actually fix upper limit. Because in actually additives, other chemical contaminants, what we do is that we actually have a concept like acceptable daily intake in case of additives, because that are not required. Otherwise, you can also avoid the contaminants which tolerable, because sometimes they enter into your food chain. So there we actually check the tolerable upper intakes. Similarly here also, but in this case, some of those nutrients we actually require. Okay, but if you go beyond the RDA, maybe beyond RDA, recommended dietary allowances for each country may be different. So based on that, we'll have an upper limit based on these data. So this data is generated, and based on that, we'll be actually permitting them in that this thing. And this is the basic requirement of safety, is to address the safety. Here, few things are important to understand. So once you have all this data, what we do is we actually try to do hazard identification. So what is hazard identification? It is known or a potential adverse health effects of a given nutrient. It can be a nutrient or nutraceutical. It involves the collection, organization, and evaluation of all information pertaining to the adverse effects of a given nutrient. As I said, the information is available. We have to pick up from wherever this type of work is done. And based on that, we'll try to identify whether this particular nutrient had any effect in anywhere in the world. Have there any case reports? Have there any epidemiological studies done? Like that, and sometimes they actually do experiments also with these things. Based on all that, we'll actually know whether this particular nutraceutical had any effect, any adverse effect anywhere. Okay. So it concludes with summary of evidence concerning the capacity of nutrient to cause one or more types of adverse. So what are the types of, based on this information, we will be able to summarize saying that what is the evidence that is coming out on this nutrient to cause one or more. Does it cause one type of adverse effect, or it causes many more types of adverse effects? All that information is actually captured in the hazard identification. So how does this data come out? It is based on the earlier slide I have shown, where we have this data. So even epidemiological, I said acute, short term, long term. So every nutraceutical doesn't need all that data. Depending upon the type, nature of that nutrient, or nutraceutical, it can be different. Okay, but essentially we are trying to find out whether it causes any adverse health effects on the population. That is the basic requirement. Once you have this information, then we try to can we actually dose dependent effect? So dose response information can we have? That is very important information, because as I said earlier slide, is that it's essentially dose dependent. If it is toxic, it should be dose dependent. So in which of the adverse effects they were able to show the dose dependent effect. So that becomes very important to derive low observed effect level or no observed effect level or UL. So this is very important. So if you don't, you are not able to generate this information, there is dose response effect in any of these studies. So it becomes very difficult for anybody to actually say at what dose this particular this thing has caused the effect. So it should be dose dependent. So we'll be looking, once we have all that data, we'll be looking for that specific information where we can derive this dose dependent effect. Okay. So all this information will help us in developing the low observed adverse effect level, no observed effect level. And the uncertainty factor is that inherently there will be a lot of lacuna in the data, or even the when we are actually extrapolating from within the humans, we expect there is a certain variation happening within the population. So taking all that things, we still use some uncertainty factor. So even that uncertainty factor will take care of, if at all there is anything which we have left out in safety factors, that will take care of that. Finally, we derive the upper limit where we say that beyond this there is a risk. So here the word I use it, tolerable, usually I said tolerable upper intake level. So the tolerable upper intake level refers the highest level of dietary intake that is likely to pose no risk adverse effects. So almost all individuals in general population, you see this tolerable upper generally, we actually, for nutrients, this physiological group is also infants and children, and also pregnant women, lactating women. All those people are separate ULs will be given. But in general, when you generally look at it, it is for general population who are apparently healthy. As intake increases, your risk of adverse effects increases. It is not just you cross UL, you immediately don't end up into having this thing, that there is risk of adverse effects will increase. The term is chosen because it connotes level of intake that can with high probability be tolerated biologically by individuals. And it does not imply acceptability of that level in any other sense. This is nothing to do with your the efficacy or any other thing. It is only to try to tell people that, okay, if you cross this beyond, you can able to tolerate this intake levels at this level, beyond which it becomes safety concern. So that is what it doesn't actually talk anything about the efficacy or the other things. So then we had an issue actually when we are actually tolerable upper intakes were there. Actually, wherever we have this as it said, dose dependent effects, we were able to derive that. But there are many number of foods that were actually we did not have any evidence of toxicity at all at the levels of what we have seen in the sense. So in such case, what do we do? So they actually, Shaw and Hathcock in 2000, these are the two scientists, they have actually developed to address this food safety issue the highest observed intake, where there is absolutely no effect has been identified. So there is no dose dependency here. Here what they are saying is we have observed at this highest level, we have not found any adverse health effects. So this is another way of actually trying to address this food safety issue where we do not have this dose dependent effect. And this is true because, as I said, when we are talking about nutraceuticals, we have been consuming them so many years. We have a lot of epidemiological data saying that we consume that much without any problem. So that can be used as the observed safe level. That latter they have actually changed this terminology is in highest observed intake. Okay, so safe actually is Actually, they don't want to actually error. They wanted to err on the safer side. They said highest observed intake. So okay, it is highest level intake observed administered as a reported studies acceptable quality. Okay. So this actually maybe some of you are aware. So this is when we are trying to say that we have because we are talking about some of them are nutrients. Some of those nutrients will be working as a nutraceuticals, and some of them bioactive compounds also will be used as a nutraceutical. So when we are talking about nutrients working as a nutraceutical, so you have to look what is the requirement. So even if the deficiency is there, we will end up having the deficiency diseases. So we have a population reference intake, then we have a recommended dietary allowances for countries like what we have for India, ICMRNA. Then there is actually tolerable upper intake level. So this is a place from where you can say that slowly the adverse effects will start. Okay, as I said, it is a risk that increases, and we cannot specifically say what exactly happens here. And second thing is there could be a lot of variation in the between the RDA and tolerable upper intake. So in some nutrients, the gap is very small. In some nutrients, it's very high. Okay, that also will give you an idea that where you actually manipulate that particular nutrients, which can have this beneficial effect of nutraceutic. So recently, what we have these people have done. These are because when we say claims, substantiation is nothing but the efficacy only. But many times claims are exaggerated, but it has to be reversed, because what happens in biological systems, if you see very high impact in the experimental, the clinical studies, when in general population, the effect may be not that big. Okay, so that's why when you want to make a claim, you should be very efficacy should be more, claim should be little less. So these are the various types of claims that are permitted. Indirectly, that the efficacy you can actually demonstrate. But the third one, this is risk reduction claims. I said because I am always coming back to regulation, because you have to go by this Indian regulation, FSSI. So risk reduction claims have been deleted from April 2022. So because people were misusing, because this very little abstract terminology, it may be very difficult to actually identify specific markers in many cases. So you can casually say it is this is risk reduction. So what these people have done is that, so they actually FSSI themselves have given some risk reduction claims permitted. So calcium and vitamin D, osteoporosis, sodium, hypertension, dietary saturated fat, blood cholesterol, potassium, risk of high blood pressure, alpha-linoleic acid, blood cholesterol, soluble dietary fiber, lipid profile. So this is how it is actually structured. It is this thing, because this we cannot change. So, okay, so when we say lipid profile, what it means is a normal lipid profile. So beta glucans, if you see that the USFDA, they are talking about reduction in cholesterol. But here in India, if you see FSSI risk reduction, they say it will actually maintain your normal blood glucose level if you take it regularly. So these are actually the one single this thing for each vitamin A. These are established. So beyond this, you need to have actually efficacy has to be proved. Yeah, that is where I am trying to say why I'm showing this particular slide is that what is actually well accepted, internationally accepted for each vitamin. Short shot is that vitamin A helps against night blindness. Vitamin D supports strong bones. So these are only the basic this thing which are acceptable. But anything beyond this, if you are actually trying to claim, so efficacy has to be done. In that context only, I was trying to tell you, you have to actually leverage of doing that between RDA and tolerable upper intake. So you see, this is actually, I have taken a slide from internet. So you see that vitamin D, these are the benefits that actually people claim. Okay, there are so many studies are done. They may be having some studies to show. But what is actually for regulatory purpose, which can be actually used for this thing, is that healthy bones. That is okay. So supports immune system, improves brain function, all those things. We should have a clinical trial to actually demonstrate the efficacy of that vitamin D. Okay. So when we are trying to see vitamin D, what is the hazard characterization? Because I told you safety aspect we are dealing with. So hypercalcemia was the only adverse effect found in the toxic studies. So there are so many different stock. As I said in hazard characterization. So hazard identification, we try to see that what are all the adverse effects which have been reported in the literature and also elsewhere in the world. We finally found that only one adverse effect, that is hypercalcemia, is the only the toxic studies of vitamin D. So in this, they from these studies, they have actually derived the no observed effects level is 10,000 international units. And I told you that uncertainty factor in this studies, because most of these studies are actually taken from the human subjects only, because the uncertainty will be less. When we are doing animal studies and trying to extrapolate it to humans, we'll be using 100 in additives. But here, in most of these nutrients, we don't require that much uncertainty, because most of these studies are done in human subjects only. So uncertainty factor, this is only to take individual variation and uncertainties in the data that is available to us. And based on that, you just divide 10,000 by 2.5, you get the 4,000 international units per day. Okay. So, but you see that RDA for vitamin D is only 400 international units. Okay. So as I said, in this case, you have a large margin of difference between UL and RDA. And probably that is the range where you are, whatever you want to actually claim on the functional properties, other than the basic nutrient function, you can actually work on it. Similarly, I have taken one more example. This is a bioactive principle, is a lycopene. Lycopene is a carotenoid, most potent antioxidant. Major sources are tomato, carrot, watermelon, papaya. High intake of lycopene is atheroprotective. That is what is reported. So it reduces LDL cholesterol, inhibits several cancer cells. So they have a lot of studies done. 6 mg per day reduces the risk of prostate cancer. So all those things are there as individual studies. But it is not still, I think there is no clinical trial to actually make a claim on that, which internationally accepted claim. Okay. So here also, when we talk about the safety issues, no adverse effects except keratonemia. That's what it means, is that the lot of this carotenoid goes into your liver, and also the color of the skin will change. So that is the only adverse effect they have found with lycopene. And lycopene deposition was observed in the liver, but it did not affect the hepatic dysfunction. Okay, so that's why it was not considered, because once you remove that, if you stop taking that lycopene, the skin color becomes normal. So it is not a permanent effect, and it didn't actually affect the liver function. So what they have done is they try to actually identify as I said, is the dose dependent effect. So there was a lot of variation, and because the IOM, international medicine, this is the US FDA, FDA, and EFSA is European Food Safety Authority. So, and these people actually, each one has a different view on lycopene. So the IOM, in which actually the many international agent, everybody actually follows this. So they said this data is not reliable, and due to lack of data, no TUL can be derived. That means they said there is no TUL, tolerable upper limit. Okay. For this, if you want to use, probably you have to look for some other source. But EFSA said they have done some work, and based on that, they have said that they have taken another study, and they said 50 mg per kg body weight per day is okay. Whereas JECFA is additive, because this lycopene is also used as an additive in foods. So there they said no ADI specified. That means at the levels of its intake or usage, there is absolutely no health hazard associated with. So then in this context only, this highest observed intake concept came, and they told that 20 mg we have seen per day consumption is safe. So not safe. This is without any effect. Okay, there is a slight difference when you say safe and without any effects. Okay, so that 20 mg per day it has been taken. So of course, I spent a lot of time on safety aspects. So of course, this efficacy is well-designed human clinical trial. So you know what happens is this nutriepidemiology, all those informations are very important, and they'll form the basis of developing a actually human clinical trial. So, but ultimately, for actually to put into the market, this well-designed human clinical trials are required for this. If you are trying to say, if you are making any claim of efficacy of any such thing, okay. So basic information like why calcium will help in bone, this thing that doesn't require any because it's already well established. But anything other than that, if you want to do that, if you want to, so you should be able to well-designed human clinical trials. So observation studies are not sufficient. And many of the probably that's what I think Madam was trying to tell you. We have to do a lot of research on the existing Indian information and Ayurveda. So that a lot of information is already available. Only thing is we have to put them in the context of what is required for the regulation, but it has to be internationally accepted. Okay, so the in vitro animal studies, all those things will actually give because you can't do all the experiments with humans. So you can get all that, biochemical basis of, because that's very important. So most, if you want to say something is effective against something, you should be able to show what is the biochemical mechanism by which this particular nutraceutical is showing its efficacy. Okay, that becomes very basic requirement.
Dr.
So,
Sudarshan,
yeah.
we are running out of time.
Yeah. Okay. I'll just probably come to because this may become little too technical for them. Okay. What I am trying to say is that so the direct measurement, this is very important, is that you should have validated because many of the diseases like NCDs, non-communicable diseases, so you will not be able to produce the disease. So you should be able to have some markers under which it is coming. Like when we are talking about asthma, cholesterol for cardiovascular diseases. So, okay, you should have validated biomarker to tell. So, this particular marker is changing. If it changes, it will definitely reduce the risk of cardiovascular disease. Something like that has to be done. And production, because this is very important in quality and all. Maybe the next speaker is trying to will talk on that. And study design, because just now Rama Vaidya madam has told that they said the number was a little less. So that is very important. Those things are also looked into for making a valid. So these are all the things. Probably I'll not go much into this. Okay. So here you see that I just now told that beta glucan, USFD says they has a beneficial effect on lowering the serum cholesterol. Is the US FDA permits this claim, but in India, help in reduction of rise in blood glucose after that meal, because you should be more concerned about FS. And of course, there are so many claims. I told rice bran oil. So you need actually 300 mg per day. For 8-week RC study, they were able to show that it can help in lowering cholesterol, but not other things are not, there is no RCTs on those. So you can actually rely on one thing. Again, you have to see that how much oil you take every day and should you only stick to rice bran oil throughout your life. So those are things which have to be understood. So to conclude, safety and efficacy are basic requirements, and observation studies or animal studies, all those things will definitely help to understand the biochemical basis of the efficacy, but human clinical trial is a must to show the efficacy. Thank you.
Thank you very much. Yes, it was very involved, very technical, but very essential